I'd like to invite Liz Cairns from the Transport Accident Commission to introduce the presenter of the conference's international keynote address. Please welcome Liz.
Thank you, Nick. Thank you, Uncle Bill, for your welcome, and Kate for sharing your very powerful story. Each year, 20,000 people are either killed or injured on our roads. And in the 18-19 year, the Transport Accident Commission in Victoria supported 58,000 clients to get their lives back on track. And that includes everything from the ambulance that someone needs to get to the hospital after a road crash, through to the treatment and rehabilitation they need to get their lives back on track, including return to work. The TAC is the Victorian government-owned organisation set up to pay for treatment and benefits for people injured in transport accidents, promote road safety and improve our trauma system here in Victoria. It's a no-fault scheme and one of the very first in this country, established way back in 1986. Our vision is clear: zero deaths and serious injuries on our roads. People's lives and health should never be the price that we pay for using our roads, and our mission is to be the world's leading social insurer. We're responsible for prevention, compensation and rehabilitation, and we're striving to be the best in the world. People in Victoria deserve nothing less than that. 3 years ago, we established 3 client divisions, and that's in recognition of the various impacts of injury, disability, and the other personal circumstances that combine to require an individualised response. Thank you. We've got 3 key return-to-work initiatives, one of which you'll have the opportunity to hear a little bit more about tomorrow. The first one, however, is in partnership with Monash University. We're trialling vocational rehabilitation in the inpatient rehab setting to understand its effectiveness in supporting patients to be more ready to return to employment. And we're not limiting that to TAC clients. We believe that we have a role to improve the lives of every Victorian. So that program is working with people who are in those settings, but not just limited to people who have sustained an injury through road trauma. We have a team of 6 dedicated return-to-work support coordinators who are focused on employment and dedicated to assisting clients with significant traumatic brain injury return to work and keep those jobs. Since the introduction of that role 2 years ago, our employment outcomes with those clients have doubled. And thirdly, we are focusing on understanding and supporting clients with brain injuries along different pathways to work. That includes pre-vocational programs, supported employment and direct placement, and support. Most recently, we've been piloting a newly designed pathway to open employment for people with a traumatic brain injury called Employment CoLab Pathway. This is an approach led by a CoLab consultant that engages and supports employers and employees, working collaboratively with providers and our staff to ensure sustainable employment, and you'll have an opportunity to hear much more about that in one of the sessions tomorrow. From all of these initiatives, we know that the person with a lived experience, their friends and family, treaters and rehabilitation professionals, employers, us as a funder and researchers get the best out of this when we work together and collaboratively. And to that end, it is my pleasure to introduce Dr. John Corrigan. John Corrigan, PhD, is a professor in the Department of Physical Medicine and Rehabilitation at Ohio State University in Columbus, Ohio in the USA, and a director of the Ohio Valley Center for Brain Injury Prevention and Rehabilitation. He is an editor-in-chief in the Journal of Head Injury Trauma Rehabilitation. He's been the PI and co-PI of the Ohio Regional Traumatic Brain Injury Model System since 1997, and chaired the executive committee of the TBI Model System Project Directors from 2007 to 2017. He's a director of the Ohio Brain Injury Program, which is the designated lead agency in the state of Ohio for traumatic brain injury policy and planning. He's a member of the board of directors of the Brain Injury Association of America and has previously served several significant national organisations, including the Commission of Accredited Rehabilitation Facilities, the Injury Control Centre at CDC, and the US Department of Defence Defence Health Board. He has more than 160 peer-reviewed publications and has received many awards for his service and research in brain injury rehabilitation, including the Brain Injury Association of America's William Fields Cavaniss Award, the 2007 Robert L. Moody Prize, and the Gold Key Award from the American Congress of Rehabilitation Medicine. I think it's fair to say that we are extremely fortunate to have Dr. John Corrigan here with us for this conference, and I'd ask you to welcome him warmly.
Well, thank you so much. It's a great honor to have been asked to come and speak to you today. Thank you to Brain Injury Australia and to the TAC for sponsoring this. I began talking with Nick more than a year ago about the possibility of coming, and talking with Nick, if you know him, is more like a negotiation than a conversation. And he wanted me to talk about my career in brain injury rehabilitation. And I'm very happy to tell you that I told him no, and that was not easy, because who would want to hear about one person's career? However, what I will be speaking to you about today is my lessons learned over a career in brain injury rehabilitation. And from the AV, would it be possible to see my slides on the screen in front of me? But I will start with just a little bit of context. And first is that in 1982, I took a faculty position at Ohio State University in the Department of Physical Medicine, because in rehabilitation, they were beginning to serve or be referred young people who had survived very severe brain injuries, mostly from moving vehicle crashes. And they were having great difficulty managing immersion from coma and the agitation and other confusion that followed. And so the task in coming and taking the position was to help a multidisciplinary group develop an inpatient brain injury program. And so January 1st of 1983, we opened that program, and I served as its program director for a number of years, 8 or 9 actually, and until we began to realize that while acute rehabilitation is really important, there was a lot of life outcomes being determined in the time after one left the hospital. And so I shifted my focus from inpatient rehabilitation to helping develop and study outpatient programs that were aimed at those individuals who are now living with the consequences of these brain injuries. And spent most of my career then providing clinical services and studying the long-term outcomes of traumatic brain injury. And just in the most recent chapter, I'm not going to call it the last chapter yet, but in the most recent chapter of my career, I've kind of brought it, I think, back around to taking on a role with the state of Ohio. Ohio has about 12 million, a population of 12 million, but taking on a role with the state of Ohio where we're trying to guide planning and policy related to living with brain injury. Taking some of these things we have learned from studying the long-term effects and trying to put them into policy. And so that's the context for these lessons learned. I think that some of them, some of you in the audience will say, well, of course I knew that, and others, you may be surprised about. So if I hit about 50% with you, that about half of these lessons learned are of interest, then I will consider it a success. So let's get started. And I'm going to be craning my neck here because I don't have the slides in front of me. The first, traumatic brain injury is more common than we think. The basis for this is a series of studies that we've done recently. But in the U.S., the Centers for Disease Control periodically publishes this summary of the annual incidence of traumatic brain injury. And it's people who die at the scene of an accident or soon after, individuals who are hospitalized, and individuals who are treated in an emergency room. This is annual incidence. But when we're thinking about living with brain injury, what we really want to know about is the prevalence of traumatic brain injury. And that's the accumulation over time in the general population of individuals who've had that experience and are now living with it. So recently there have been a series of studies done in the U.S., in 3 states in the U.S., using techniques we've developed for trying to get reliable and valid self-report of one's lifetime history of traumatic brain injury. And these 3 studies, they cover some 16 million lives, have given us some new insights into how common or the prevalence of traumatic brain injury. So the 3 states, in Colorado, they dedicated the whole interview on the telephone interview to determining lifetime history, so they were able to ask a lot more questions. And what they found, to our surprise, frankly, was that some 42% of individuals had had at least one traumatic brain injury, using the typical case definition of that, at some time in their life, higher than we expected. All 3 studies allowed us to at least ask if somebody had had a traumatic brain injury that was severe enough that it caused loss of consciousness. Now, that's not all traumatic brain injuries. Some don't cause loss of consciousness. But when you're doing retrospective self-report, it's an easier handle to get on. And when we looked across those 3 states, it was a pretty consistent result that some 1 in 5 to 1 in 4 non-institutionalized adults in these states had had at least one traumatic brain injury in their life that resulted in loss of consciousness. The method we used also allowed us to look at the severity of their worst traumatic brain injury. And as you see here, again, a relatively consistent picture of, on average, about 4% of the non-institutionalized adult population had at least one moderate or severe traumatic brain injury sometime in their life. So what that means, if you were a general practitioner and you had a practice that was, served the entire range of adults in your community, you would expect that of those people you're treating, some 1 in 5 or 1 in 4 had had TBI with loss of consciousness, and 1 in 25 had had a moderate or severe traumatic brain injury, definitely a more severe TBI. We'll talk a little bit more about childhood injuries before we're done this morning, but we have been concerned for some time about earlier life traumatic brain injuries, even when mild, having an effect later in adulthood. And we have used an injury with loss of consciousness before the age of 15 as kind of a cut point, as you're going to hear in a little bit. We are rethinking that. But what you see here is somewhere around 8% or so of adults had had a TBI with loss of consciousness earlier in their life. And when you combine the 2 risk factors, if you ever had a moderate or severe traumatic brain injury or ever had one with loss of consciousness before age 15, it results, in North Carolina they used a different cutoff, so I couldn't include those, but from the 2 other states, some 11% on average of individuals had one or the other of those risk factors in their history. This, in terms of relative risk, this of consequences, living with consequences, it doesn't have to be disability due to traumatic brain injury, but having a consequence that persists, this is a much higher rate than what we expected. And we'll come back to this slide, as a matter of fact, before I finish today. So, traumatic brain injury is more common than we think. So this is a quiz for you. Pick the best fitting answer here. TBI is a life-altering injury for survivors and their families, profoundly impacting the patient's functional status. Or B, traumatic brain injury is a very common injury that is essentially inconsequential to the individual's functional status following recovery. Or C, it is both A and B and everything in between. And because I know you are all good test takers, you all figured out that C is the answer that I wanted you to choose. But indeed, traumatic brain injury and its consequences are a very variable, and it's a very large spectrum of outcomes. So that leads to the second lesson learned, and that's that the broad variation in consequences is a barrier to public and professional understanding. So if you've been in the brain injury field, you've heard the expression, you know, if you've met one person with a concussion, you've met one person. And in the brain injury field, we use that to remind us not to make generalizations about the impact of brain injury that from one individual we're working with to another. But actually, this goes a little further for me, and I want to add to it and say, if you knew I had a traumatic brain injury, you really know nothing about me. That could have been a traumatic brain injury that happened several years ago, very mild, completely recovered, I'm fine. Or it could have been a traumatic brain injury that resulted in persistent coma, and I am still experiencing the effects of it. And where that is important is when we're thinking about particularly professionals across the spectrum of healthcare and social services who are not brain injury professionals. And if all they know is that we've had a traumatic brain injury, or if that's all we tell them, and they don't understand this great variability in the presentation of traumatic brain injury, then it will be easy for them to make incorrect assumptions about who we are and what our abilities are. So this is a slide I actually use in teaching quite a bit, just to make this point. And from the left there, you just think of a continuum of severity of any one traumatic brain injury. And from the left there is the least severe to the right, the most severe. Along the least severe end of the spectrum are those traumatic brain injuries that only result in, say only, being dazed, confused, or a gap in your memory. You remain conscious, but it does alter brain functioning. Next most severe are those that result in loss of consciousness. And finally, at the most severe end of the spectrum is those that result in coma, where there's actual, not just unconsciousness, but a change in basic reflexive functioning of the central nervous system. So this continuum is actually a little bit understandable. If you weren't in the brain injury field, this might be something you would get. But we made sure it was going to be difficult for other professionals to understand severity by calling mild traumatic brain injury, sometimes concussion, sometimes calling it concussion, sometimes calling it mild traumatic brain injury, and having it span not just being dazed, confused, and having a gap in memory, but also including up to 30 minutes loss of consciousness. And then we called moderate those that were longer in loss of consciousness, but not necessarily involving coma. It gets a little more tricky there. And then our severe traumatic brain injuries, those involving coma. Well, we know that the severity of the injury is a big determinant of consequences, but this complicated way of characterizing severity makes the transparency into understanding TBI by professionals, other professionals, more difficult. And sometimes I have to admit, even among rehabilitation professionals, sometimes we don't see this appreciation of the full range of severity. So then, it's not just severity. The severity of the injury is not the only thing that determines consequences. It also, more recently, we've become aware how cumulative effects of having more than one brain injury, including multiple mild traumatic brain injuries, can have later consequences. So in the U.S., we became very concerned about professional football in general. You have not been without your concerns here, and these are just the football sports. There are other contact sports that also carry high risk for multiple mild traumatic brain injuries. Our wars in the Middle East, and particularly the use of improvised explosive devices, also then brought awareness that our military members who were exposed to multiple mild traumatic brain injuries, whether of a blast or traditional mechanical methods, were also getting this exposure like we were seeing in sports concussion. So the cumulative effects, in addition, even when mild, cumulative effects of multiple make a difference, but it's still not that simple because it's not just a number. A count alone does not tell you what the likely consequences are. I think we are tending to be more interested in the spacing of injuries, and particularly not having the next one before the last one healed. But there's still a lot of work going on in that respect. So we've made the understanding of likely consequences more difficult there as well. And when we think about these multiple mild traumatic brain injuries, our minds go to contact sports, and it goes to our military members who may have been exposed to blasts and other sources. But there are other populations that also experience multiple mild traumatic brain injuries. Victims of intimate partner violence. And tomorrow we'll be hearing from colleagues in Canada, and we know that what Brain Injury Australia is doing here about intimate partner violence are really some of the leading thinkers and advocates about how this population also is experiencing multiple mild traumatic brain injuries. People who start to misuse substances, alcohol and other drugs. We know from looking at the course of lifetime history that once you start to be regularly intoxicated, the number of traumatic brain injuries, usually mild, but not exclusively so, just skyrockets, whether that's having poor balance, falling down steps, having poor coordination and ability to manage the motor vehicle and having a wreck, having poor judgment and saying the wrong thing to the larger person in the bar. These things all result in multiple mild traumatic brain injuries, so this population too experiences that. And there are other vulnerable populations, whether it's those with psychiatric disorders, the homeless, and those who are incarcerated inmates, prison and jail, that we see when we look at their lifetime histories, they too have experienced multiple mild. So this cumulative effect is not just football players, boxers, and members of military who've had combat exposure. There are a number of individuals in society who experience multiple mild or cumulative, likely cumulative effects of multiple mild traumatic brain injury. So severity, cumulative effects, but the age of injury is also a factor. And one of the things we are starting to appreciate is that an early developmental exposure, even to a mild traumatic brain injury, may carry very specific kind of consequences into adulthood. I wonder about normal aging and how normal aging might be further affected by a mild traumatic brain injury in an older adult. Not much research there. The childhood injury we're going to look at more before I finish today. How recent is another factor. You know, a mild traumatic brain injury that happened last weekend is going to present and be affecting a person much differently than a mild traumatic brain injury that happened 2 years ago. So we sometimes get lost when we're thinking about history and prevalence, et cetera, and forget that recency and not having healed yet from that last one, even if mild, is a driver of consequences. And finally, another kind of version of cumulative effects is if you combine a traumatic brain injury with some other compromise to the central nervous system. So where we become acutely aware of that is in intimate partner violence of late, where there's a high rate of choking or anoxic, hypoxic or anoxic injury, as well as a high rate of traumatic brain injury from being hit in the head. Or in opioid use, overdoses, that we are seeing individuals who have multiple experiences of hypoxic brain injury combined with a traumatic brain injury. So cumulative effects also occur in terms of other acquired brain injuries, but other compromise in general to the central nervous system. So this broad variation that we just kind of did a very quick review of is a barrier to being understood in the larger professional community, if not in the larger public. And at least I forget to say this, that I think it's a barrier we need to overcome. I don't think we can accept that the physician you might go to, the nurse you might see in the emergency department, the substance abuse counselor you might go to for a drinking problem wouldn't have a better understanding of the extent of one's history and how that might be playing out in behavior today. 3, TBI is disproportionately related to problems regulating cognition, emotion, and behavior. So TBI can do a lot of things. I'm not limiting it to problems in regulating behavior, meaning knowing when to stop, knowing when to start, knowing how much of a emotion or behavior to exhibit. But self-regulation has a special place in traumatic brain injury. This is a study done by the Institute of Medicine, now known as the National Academy of Medicine in the U.S., where they noticed mild traumatic brain injury and how strong was the evidence at that time for an association between these different longer-term outcomes and having had a mild traumatic brain injury. And so all of these were either considered evidence of association or suggestive association. Both categories considered relatively high in terms of likely association. And what I've highlighted there are some of the associations then that are related to my thinking to problems of self-regulation. A study we did in the state of Ohio that not only do we look at prevalence, but we looked at what is having a history of traumatic brain injury related to in terms of other health and related behaviors. And this is the list from a series of studies. And what you see again in yellow are those associations, all significant, all adjusted for sex, age, and race, ethnicity. Those associations that in my mind, are related to self-regulation. So if we look at prevalence again, and you may not realize it, but what you're looking at here is what you just looked at a few minutes ago, the results from those 3 states when they just surveyed the general population of adults, non-institutionalized adults. So from Colorado, 43% any TBI, then the average there from the 3 states for having had TBI with loss of consciousness or a moderate or severe TBI. So how does that compare to other populations we see in special settings, particularly settings where we're treating problems of self-regulation? Excuse me. A series of studies that my colleague Jenny Bogner and I did in Ohio, where we went into drug and alcohol treatment facilities and did prospective screening of individuals being admitted, what we found is a much higher rate overall, as well as almost double the prevalence of TBI with loss of consciousness, and some 4 times as many having a moderate or severe. An old study, I probably should quit using it, but of psychiatric inpatients found a similar kind of picture in terms of the prevalence of history of traumatic brain injury. A very good meta-analysis by Sharoma and et al. A few years back, as well as other studies, have found among those who are incarcerated a very high rates or prevalence of traumatic brain injury. And in studies of the homeless, and I could add to these, but there are still newer works, but they all are coming up with the same kind of result. And that across the board, what we're seeing is a much higher prevalence of a history of traumatic brain injury in these populations that I would suggest to you are all, being in the population is marked by a problem of self-regulation. So that out here, when we look at how many people in that setting have had a moderate or severe traumatic brain injury, while we'd expect 4% of the general population, we're seeing 3 to 4 times that prevalence in these various treatment populations. So it's disproportionately associated with problems of self-regulation. And again, it's not the only thing that's not the only consequence, but it does mean from a larger societal point of view that we have, in these settings, we need to be thinking even harder about what are the implications of a history of traumatic brain injury among the persons who are homeless, among individuals who are having problems of substance use disorders, those who are incarcerated and in our prisons. Lesson 4. Damage to the frontal areas of the brain is the source of problems in self-regulation. So there's a unique way, particularly in traumatic brain injury, that the brain is being affected that lies at the core of why we see so many problems of self-regulation. And so, what I have said for a long time is that while anywhere in the brain can be hurt, the fingerprint of traumatic brain injury is damage to the frontal areas, the frontal lobes and the interior tips of the temporal lobes. Why does that happen? Well, we know when there is an external force, something hits the brain, the head hits something, even exposure to blast, that if there's sufficient force, the brain moves within the cranial vault. It jiggles within the cranial vault. And for the most part, that's okay because the inner surface of the cranial vault is smooth. However, in the front area here, and this is the front, there are a few bony ridges that the cortex sits in. And when the brain jiggles, it scrapes across those bony ridges, resulting in focused injury, contusion, bruising in the frontal areas. This shows the frontal lobes, but it also is true of the anterior tips of the temporal lobes. And whether it was the early studies that were done by Corrigan, where they did in autopsies, looked at a series of persons with traumatic brain injury and where their bruising was, or it was more recent studies using MRI that we see in particular, not only is it the frontal areas, but this bottom of the front, or the orbital frontal cortex, which many feel is kind of the source of the brakes that we develop in development, the brakes on behavior. When we can say, wait a minute, that may feel good to do that, or I may want to do that, but maybe I shouldn't. And those brakes are associated with these parts, the orbital frontal cortex of the brain. And it's not just bruising and contusion. Some of the connections from the midbrain up to the frontal areas are particularly vulnerable to being sheared and torn because of the way actually the tissue is so packed in there and it sits on different planes. And when you get a jiggle, when there's a jerk, a movement of the brain, inertia causes different parts of the brain to move at different speeds, and that then causes shearing and tearing. You may think that this is a depiction of injury due to traumatic brain injury. This is actually the classic depiction of addiction and the pathways that are thought to serve various addictive behaviors. And it's the midbrain to prefrontal cortex connections that are highly associated with that. So in our, with our ever fancier imaging, we still see. This is diffusion tensor imaging showing that, it looks like we lost a little bit of the labeling here, but this is diffusion tensor imaging showing that these frontal areas are more susceptible to this disruption of the myelin sheath, the coating, which then disrupts transmission. So this damage to the frontal areas of the brain is the source of these problems in self-regulation. As a result of particularly, well, all four of those, frankly, being common, it being a problem of self-regulation, the frontal lobe connection, leads me to conclude that it's very reasonable that whoever the professional is, whether in health or in social services, that professional needs to know whether the person they're working with has had a traumatic brain injury. Which brings me to number 5, and that's that every healthcare and social service professional should know the lifetime history of TBI for the individual they treat. So we have developed more recently various methods for getting at lifetime history. I won't do the full lecture I usually do about all the various ways of characterizing the brain and brain injury, but retrospective self-report for getting at lifetime history is still our best method. And all of these tools have been developed and validated for some aspect of that. What they're particularly good at is being able to say, this history, the history you're able to tell me about, is likely to be affecting you today in some way. And we believe that screening and the use of screening by professionals across the spectrum, by healthcare and social service systems across the spectrum, is a critical next step to being able to serve everybody with a traumatic brain injury, not those who are only being served in rehabilitation by rehabilitation professionals. But it's not enough. If we just screen and that's all we do, it's kind of all dressed up and nowhere to go. And so this slide just shows a resource that we developed a few years ago to train professionals who are not brain injury professionals to think about simple accommodations for these frontal lobe, sometimes called executive function problems, these neurologic aspects of brain injury, so that when they detect, they also have some skills for understanding how the consequences of brain injury may be affecting what they're doing as a social worker, in the housing program, or what they're doing as a nurse in the home health assessment. And frankly, it's even not enough that they would have the screening capability and that they have some understanding of how you might accommodate a neurologic problem. I also believe that there needs to be a shift in the thinking of most help givers from assuming that the behavior they're seeing in an individual is because it has a psychological basis or a motivational basis, that it's intentional, versus that much behavior is. But there is also behavior that results from a neurologic condition, from this damage, in particular to the frontal areas. So if I missed an appointment to see my substance abuse counselor, it is very common in the States, at least, and I think here as well, for the assumption to be that this is a reflection of my motivation, that I'm not quite ready to change yet, or I would have been here. I wouldn't have missed it. While those of us in brain injury rehabilitation know a missed appointment can be as simple as not remembering to set the alarm, not being organized, not having your to-do list out there. And it doesn't reflect whether or not you wanted to be at that appointment. It does reflect some of these problems, these neurologic issues that come with particularly injury to the frontal areas of the brain. So getting healthcare and social service professionals to think about alternate hypotheses, not to just jump to the conclusion that something is intentional or a reflection of motivation, is a critical change in the culture of the helping professions that I think is the rest of the story, with screening, accommodation, and readiness to see things more than one way. I sometimes use the example that if you were talking to an 80-year-old individual about their high school experience and they couldn't remember the name of a teacher, we will mostly think that that's a problem of memory that's associated with normal aging, frankly. Just that was a long time ago. We make a neurologic conclusion about why they didn't remember it. The psychological conclusion would be, oh, you must have hated that teacher because you can't remember their name today. That's the psychological conclusion. Perhaps they did hate that teacher, but the point is that there's two possibilities here. And what I always remind professionals is that if you then said to that 80-year-old person, you must have hated that teacher because you can't remember their name today, and indeed it was their favorite teacher, what do you think you're doing to your relationship building with that individual? Any reasonable person would conclude, this guy doesn't get me. He's jumping to conclusions about me. So that's what I'm talking about, this neurologic versus psychologic hypotheses about the source of behavior. So that's the skill set and the understanding I'd like every healthcare and social service professional to have. Number 6, even mild traumatic brain injuries in childhood can have adult consequences. And I kind of warned you that this was coming. I'm a little afraid this is a little wonkier part of my talk, so if you'll hold on to your hats and if you need a nap, this might be a good time. No, this is some of the most interesting part of this talk, so please stay alert. Some work done by Audrey McKinley, who's been here in Melbourne, and but work that she did when she was in Christchurch with the Christchurch birth cohort, was some of the early indications to us that these childhood injuries, even if mild, may have more impact than we think on later behavior. And what she found in this summary of some of her findings was that that it wasn't the mildest, they were mild traumatic brain injuries that required at least a day of hospitalization, that those children later were more likely to develop substance use disorders. I should be clearer, I'm sorry, that those who had that injury before the age of 6 were more likely to have later substance use disorders. She also found in later follow-ups that those with their first injury in adolescence, late adolescence, also had a greater vulnerability to drug dependence in this case. Her work, there are a number of articles that were based on this work, and she identified a number of consequences. And this is the kind of information that a well-done birth cohort can provide us in understanding childhood injury adult consequences. Unfortunately, birth cohorts are very, very expensive to do and take a long, long time to give their results. So we've developed other methods to look at it. A study that I was part of with what's called the TBI model systems in the States, where we're following about 17,000 individuals who've had rehabilitation for traumatic brain injury, and we're following them at 1 year post-injury, 2 years, 5, 10, 15, 20, and every 5 years thereafter. We have some now who are in the 25-year post-injury. But one of the things we looked at was, well, was this injury, they had to receive acute rehab for the injury, so it's a more severe one for sure. But was this their first one, or did they have some before? And what you see here is when we looked at injuries that preceded the one that got them into rehab, that there was a much higher likelihood that they also had a prior alcohol misuse problem if that earlier injury happened before the age of 6. So if it was in 0 to 5. And it was marked higher. The red bar, by the way, is those who had no prior injury. Their first injury was the one that got them into rehab. We saw a similar effect when we looked at having received any mental health treatment prior to coming into rehab, prior to the injury that got him into rehab. This seemed to be supporting some of the work that Audrey had been publishing already, and got us very interested in actually this whole up to age 15, when you had a traumatic brain injury up to age 15. An idea that we are now amending because of a study, a very large study now, done a different way. This study and several out of Scandinavia are able to combine registries from healthcare, from social services, from education, across government programs and non-governmental programs, and combine them and look at the individual, identify the individual in all those registries and see what, in this case, what the effect of a childhood injury is having on then a series of adult consequences. And they also made two other comparisons that were very important. One is they compared them to, not just to the general population, but to individuals who had an orthopedic injury, because some believe that some of what we may see in these adult consequences is more due to a personality style, maybe somebody who takes risks, and it's just a matter of luck whether it results in a broken leg or a traumatic brain injury. And they finally then also looked at siblings who had not had a traumatic brain injury and whether these adult consequences were more likely than for the unaffected sibling. The kinds of things they looked at were whether they received psychiatric treatment, and this was basically through early adulthood, any hospitalization, whether they had died, which would be prematurely given their age, disability from work, receiving welfare benefits, or low educational attainment. And this is the part I'll just ask you to hold on to your seats, but what they found when they just compared in terms of basic demographics was there was elevated risk in all these outcomes for those children who had had a traumatic brain injury. So what that means is that they were, if you look at having any psychiatric visit in their lifetime, they were 50% more likely, 52% more likely to have had a psychiatric visit if they had also had a traumatic brain injury. But when they controlled for the family situation, the socioeconomic status, and some of the characteristics of the parent, those odds came down a bit, but they remain statistically significant. So now, instead of being 50% more likely to have a psychiatric visit, you are 37% more likely. And the interesting question to me was, okay, now if we throw in unaffected siblings who didn't have a traumatic brain injury, how does that look? And what you see is that it remained significant. There was a significant risk, but it wasn't that much less than just when we looked at family things. So looking at unaffected siblings, we would conclude, helps us understand the family environment, the family and community and socioeconomic factors. So this is all saying that all of these early adulthood outcomes are more likely with a childhood injury. But what about when that injury occurred? How old? And they looked at the age at which the first traumatic brain injury in childhood occurred. And across those consequences, what you see is that in general, all remain significant. If it's on the page, it's a statistically significant greater odds of the outcome. However, as the age at injury got older and got into adolescence and late adolescence, that the odds actually went up. So now, this was without comparing to unaffected, uninjured siblings. What about uninjured siblings? And this, for me, is when it gets interesting and I get wonky, sorry. You see that many of the odds, particularly for the youngest age group, disappear. They're no longer more vulnerable than their unaffected, their sibling without. I can't go into all the logic behind this, but what we think is that in a household where there are positive influences, parenting and otherwise, that the effects of an early life traumatic brain injury may be mitigated, may be able to be addressed, and then you're no more likely than your unaffected sibling of having these consequences. When we just limited that to mild traumatic brain injury, so none of the individuals had anything more than a mild injury in their lifetime, it changed it a bit more. It made premature mortality go away. That's a good thing. It reduced some. But the concerning thing to me is that out here in the 15-year-olds to 24-year-olds, the odds still remain awfully high for a number of these consequences. And so, it might make sense that for children who have injuries younger in age, that we, as we do now, are looking not just at the child, but at the parent and figuring out how to give the parent the resources to be a positive influence on essentially retraining that child's behavior. But in adolescence, we may not have that same opportunity through family to make that intervention. So how are we going to do it? How are we going to work with these adolescents and young adults having even mild traumatic brain injury? There's a study that we hope to be published next year based on I think it's almost 9,000 Ohioans, where we found in particular that adolescent, anywhere from 10 to 19-year-olds who had their first traumatic brain injury in that period were more likely to develop adult substance misuse, excessive drinking in particular, and that unfortunately it was a little bit more pronounced in females than males, but existed for both. So I hope you've been able to go on that little journey with me. You might have guessed that this is an area I'm doing current research on and you have great interest in. But even mild TBIs in childhood have adult consequences. We're almost there. There's only 8. On the other end of the spectrum of severity, however, are those with the more severe, moderate and severe traumatic brain injuries. And what we are learning, particularly from longitudinal studies, is that more severe TBI should be thought of as a chronic health condition and requires proactive management. And I'm going to do this relatively quickly here. But a large study that we did in collaboration with the Centers for Disease Control in the States looked at mortality due to traumatic brain injury, after traumatic brain injury. And it was a large portion of the TBI model system sample, some 7,300. It represented more than 20,000 person years of life, which in mortality work, I understand, is considered a very nice sized sample. Then we weighted it to the national population. So everybody in the U.S. who, as an adult, had received acute rehab for a traumatic brain injury, and that was some 156,000 lives. And then use mortality rates, population-based mortality rates, based on age, sex, and race ethnicity over a 5-year period to say, do the individuals who had rehab for traumatic brain injury have a greater likelihood of death in the time following the injury? And what we found is, kind of cutting to the chase, there's a statistic used in mortality called the standardized mortality rate. And to the extent it's larger than 1, it means you're more likely than individuals with the same age, sex, and race to die. In this case, after traumatic brain injury. If you live to 1 year post-injury, the odds went down. That's a good thing, but you were still 50% more likely. We saw it, depending on the age in the far left there, the age at injury, it was still significant, except all the way up to age 85. Only the 85-year-olds and older were not more likely than their peers to die after a traumatic brain injury. And you can see, as you might expect, that the younger the person with brain injury, the higher the excess mortality, just because younger people are less likely to die. More important, though, to the lesson learned, is that when we looked at cause of death, it was really a remarkable array of diseases, disorders, and events that were shown as the primary cause of death. And in all cases, showing excess mortality, except for digestive disorders. That was the only disorder that you weren't more likely to die of. So whether it was another crash, a vehicular crash, suicide, respiratory disorders, seizures, you might guess, up at the top there, circulatory disorders, stroke, all these comorbid conditions and other events were more likely in the group with traumatic brain injury. And so this and some other data kind of looking at how people do over time contributed to a change in our thinking about traumatic brain injury, at least more severe ones, to thinking of it as a chronic health condition, the way I put it, but a disease process rather than just an event in time. And if an event in time comes from, it's an injury. There's a period of healing, and you expect a certain amount of stability after whatever that amount of healing time is. But as a chronic health condition, what it's saying is there's been a change to the organism, and now we've set up some kind of underlying process that's made it dynamic, and it will change over time. And unfortunately, what we've seen is that if not without other interventions, the tendency is to have decline over time. That's more likely than continued improvement, or it's more likely than staying the same. So this will be hard to describe quickly, but these are now not deaths. These are people who are alive. They lived to 10 years post their injury. And the green line shows everybody, basically, what the trajectory of, in this case, motor function is for everybody. And you can see there is a slight dip in it. That's that decline over time factor. But if that individual, among those individuals who had, in this case, myocardial infarction, heart attack sometime in their life, while in the beginning their motor recovery looks about the same, by the time they get to 10 years, they've had significantly greater decline. And it's this kind of finding that's led us to think that this development of comorbid conditions, these later events, are interacting with a traumatic brain injury in some way, and we need to be thinking about that, not thinking of it as a stable event. So with depression, again, motor function, that we see a greater decline, particularly in the later years, 5 and 10 years post. As you might guess, if we look at cognitive function, the relationship with depression is way more marked. and that there is, from the beginning, more impaired cognition in the presence of depression. So in the end, what we found were a number of comorbid medical conditions that, when they were in the presence of brain injury, accelerated essentially the overall decline that we saw in everybody, whether it was motor function or cognitive function. So if the importance of thinking about this as a chronic health condition is that we would approach living with brain injury differently. It would be more like what in the States has been called disease management approaches, like what we do with diabetes, where we're saying, now you have this, so we need to do things differently to maximize your outcomes. And what that would look like, this is from an early Institute of Medicine report, is that we would set up surveillance, watching for the development of complications early and prospectively. Not just wait for the complication to occur, but have monitoring in place over time. We would have protocols then for those complications that are more serious or more common of trying to prevent them. So if gaining weight turns out to be a source of losing function, then let's be on the front side of that and look at nutrition and exercise from the beginning and prevent the development of obesity, for instance. We need to involve the individual and family in self-management. Every kind of chronic health condition or disease management approach, that the core of it is self-management. You only spend about 4 or 5 hours a year with a medical professional. The rest of the time, you're with yourself. So if we can figure out how to engage the individual in proactive surveillance, in preventive behaviors, that's where we're going to make a real difference. There's been a lot of work done in self-management and other conditions, but what we haven't really looked at is after traumatic brain injury, with some of those executive function or frontal area damage that we've looked at, do we need to alter how we do self-management and take a different approach? 5 minutes. Access to medical care. So if we find complications, we need to have them treated. More of a problem in the States, I think, than here for many, but it's no good to identify something proactively if you can't do something about it. And even more important to me is the ability to re-optimize functional function. So that what we see is, over time, motor function is declining. Over time, cognitive function is declining. We should be able to use therapies strategically to kind of do a booster shot in terms of motor function, cognitive function, and other abilities across the lifetime of individuals with more severe injuries. Because it's pretty clear that as you start to lose function, then the pace of decline picks up rapidly. So that's more severe TBI is a chronic health condition that requires this proactive management. And finally, the public health burden, and that's epidemiologists' words for it, the public health burden of traumatic brain injury is greatly underestimated. Public health burden uses a number of statistics to try to compare various diseases and conditions to say, well, how much is this affecting society? How much resources? And in this case, how much loss of life, premature loss of life, how many years of living with disability are a result of that condition? To be able to calculate those kind of things takes the ability to count or measure a number of constructs. And while I won't be doing it for you today, you say, thank God, these are, each one of these actually have a kind of a special case in traumatic brain injury that in my mind is leading to an underestimation of those statistics at the top. When we look at death, premature death, what is counted is only those deaths that occur at the time of injury or in the few days after. They don't think about, as we looked at earlier, the excess mortality that's happening over time. And those of you who are listening carefully know that what we looked at the statistics were more severe traumatic brain injuries. But a study out of Scotland showed that even for mild head injury, there was excess mortality, and I'm just going to have you look at those with injury before age 55, that those who had a mild head injury, only mild, were 4 times more likely to die in the subsequent 15 years, and even twice as likely when compared to those who had some other injury but not a head injury. So there's even excess mortality in mild traumatic brain injury. So using just the number who are injured at the time of die at the time of the injury is a significant underestimation of years of life lost. And I'll just remind you of these statistics we looked at earlier. While I would change the risk factors now and extend it later into adolescence, so these percentages would go up, that we think there's at least 11% of the general population, 11% prevalence in the general population of individuals who are essentially at risk or carry consequence today from a prior traumatic brain injury. So, this isn't going to do well. Sorry. But this is in the States for a number of neurologic conditions, what prevalence they estimate is. And there in the red, you see traumatic brain injury. But that's because it's estimated at 1% currently by the Centers for Disease Control. If it were 11%, it would look more like this. It's way more dramatic when this is scaled correctly. Sorry about that. But which of these numbers do you think is going to get more attention? Which do you think is going to get more resources for addressing long-term consequences? And your guess, I think, is the same as mine. So that's the public health burden very quickly. So I'm going to wrap up here. So these are, I'm not going to read these because I'm getting a crick in my neck, but these are the 8 lessons from my career in brain injury rehabilitation that I've learned, that I think that we should learn, and that more importantly the larger society should understand. So I'm just going to end now with a couple quick slides about the kind of the so what. Well, I have been given a version of this talk. I've been told it's depressing. Sorry. But these are odds. These are not death sentences. These are odds. This is, some are more likely and some are less likely. So I always like to end by reminding that the individual can commit to a brain-healthy lifestyle and significantly change their odds of which side of these outcomes they're on. And those brain-healthy lifestyle changes include avoiding any more TBIs, pretty good advice, I think. Nutrition, your exercise, getting at least 7 hours sleep. These are all things with a significant evidence base for it being better for long-term, particularly cognitive function, but overall health. Don't drink alcohol or use illicit drugs. I'm on the don't side after traumatic brain injury. Others say moderate. Stop smoking for sure. Be engaged. Seek to minimize the stress in your life and develop methods that will help you be more proactive about managing stress. Now, you don't have to do all of these to change the odds. You just pick some and start to make changes. And for the individual who can say, actually, all of those are true of me, you're going to live longer than I am. And I have not had a moderate or severe traumatic brain injury. I then would say, what's the government responsibility? And I'm going to be very quick here, Dick. That first is to have good data for planning and policy. And as several of the points I've made today is where we don't have good data. we don't really know about the prevalence and consequences of living with traumatic brain injury that we should. We need the entire field of healthcare and social service professionals to be way more sophisticated about what they understand about traumatic brain injury, what they understand about risks for later consequences, what they understand about human behavior and neurologic versus psychological sources of behavior, and have a skill set for accommodating some of these neurologic deficits in their interactions and in their treatment planning. We need to be implementing these kinds of best practices in service systems that have a disproportionate number of individuals with histories of traumatic brain injury. So, we already, in most developed countries, do best practices on the list on the left, but I'd argue it needs to include our behavioral health care, our substance abuse and mental health care, our work with older adults, our programs for older adults, the criminal justice system, including juvenile justice system, very important, our persons who are homeless, and finally, domestic violence. And I really want to thank Brain Injury Australia for having taken a lead in making this a more important population. It is the emerging population that we're becoming aware of have special needs associated with both traumatic and other acquired brain injuries. And so finally, the last thing I would think that governments need to do is to educate the public, and particularly our elected officials, on the issues being confronted by persons with traumatic brain injury and their family. And with that, I thank you.
Sorry about your neck. Dare I say, unlike a lot of international keynote speakers who fly in and fly out, John is going to be here for the entire 2 days. So I thought, rather than cutting in to morning tea with 300 or so mouths to feed, John will be here today and tomorrow, so he's certainly available to take questions directly from you. Enjoy morning tea alongside networking with the 380 or so other delegates from every state and territory, New Zealand, the US and Canada. Please, by all means, visit the exhibitions as well. Enjoy your morning tea. I'll see you at 11:30.